There's a concept of deafferentation, which means the loss of normal and expected sensory barrage. And we use this in the concept of functional deafferentation, where the loss of normal and expected sensory barrage is most common from a limitation of joint range of motion. So let's say I'm a vertebra, kind of a big vertebra, and let's say I normally move back and forth, like so. Maybe I'm about a T8 vertebra, maybe. And let's say I'm moving back and forth. And let's say over a period of time something happens and my latissimus dorsi on one side gets shortened and it won't stretch, and there's a need for fascial release technique in my left latissimus dorsi, and it won't stretch. So instead of moving back and forth all day long, I move back and I can't move forth. Move back and I can't move forth. And as a result of being in this position over and over again, I get subluxated. And so I can't move back and I can't move forth, even worse, because of muscle imbalance and a subluxation. And so then the chiropractor comes along and says, I'm going to free that up and adjust me, boom, and I move back and forth again. And all of a sudden I move back and forth, but that fascial release has not been done. So little by little I wind back down, I limit my range of motion, I still subluxate again, and the lat's too tight on the left and I can't move, I can move back but I can't move forth. What happens to when I can move back and I can't move forth? Normally in normal movement there's a stimulation of muscle spindles through all the muscles that are firing, it's turning on and off. Joint receptors, of course, are firing. Even skin receptors and fascial receptors are firing. Golgi tendon organs might be firing, depending. All these different receptors are firing, and they're driving the nervous system. They're driving nervous system function. There's a bombardment of afferentation, normal afferentation, bombarding symmetrically and equally the spinal cord, the brainstem, the cerebellum, and the cerebral cortex. Up and down, equally, symmetrically, optimally functioning, driving the function of these neurons. But let's say we get this problem with a subluxation, there's a fascial sheath involvement. So all of a sudden I'm moving back but not forth. All that fourth range of motion is decreased in its sensory input. We're not getting stimulated those sensory receptors. There's a deafferentation of the sensory receptors of this whole fourth range of motion. And so that means the muscle spindles, Golgi tendon organs, joint receptors, even fascial and skin receptors are, on the other side, aren't being stimulated. And so we don't get the stimulation, and on the side that's restricted, if we come along and we release the fascia by spray and stretch technique or by fascial flushing or fascial release technique, if we then adjust the T8, boom, and bombard it back in its range of motion and we free the muscle fascial shortening up so we have full range of motion, now what we've done is we've restored normal afferentation. So the spinal cord, brainstem, cerebellum, very important, and cortex and all places in between now is getting equal bombardment with afferentation, restoring normal activity on both sides of the body and restoring normal activity on both sides of the central nervous system. And that's not a small thing to do, that's a huge thing to do, because the nervous system is dependent on normal afferentation from mechanoreceptors, joint receptors, muscle spindles especially, to stimulate pathways that are dependent on that stimulation. We are made to move. We live in a world of gravity. If nothing else is firing, muscle spindles are firing in reaction to gravity and in reaction to our breathing. There's always something firing if we're alive. And there are things that are firing, the basal level of things that are firing are muscle spindle receptors, which are mechanoreceptors. They're always driving our nervous system. And so if we have deafferentation, the more deafferentation we have, the less we have driving of normal pathways. It requires mechanoreceptor activity to block pain. Nociceptors come in the spinal cord, do three things. They go forward and create a transmission to higher levels where pain can be perceived. They go up to the brainstem and to the cortex, spinal thalamic pathway, spinal reticular pathway, and spinal tectal pathway to the brainstem and to the cortex for perception of pain. They create a muscle withdrawal reflex. It's called a flexor reflex afferent response, a muscle withdrawal response. And it creates an autonomic effect which causes a vasoconstriction at the same segmental level of the area where we've been injured so we don't bleed to death. When we get that problem, those three things are all excellent for blocking the effects of the injury. But what we want to do is we want to restore normal. We want to restore the patient so they don't have pain. We want to restore the muscle balance so it supports the tissues that have been injured and they can heal better. And we want to restore circulation. We want to restore that vasoconstriction to a normal vasodilated or normal vasoactive state so that we can supply nutrients and carry away waste products at a normal level. So the initial reaction to injury is protective, but what we want to do is we want to restore that to pre-injury state as the body is trying to heal itself, and we can aid it by improving that by stimulating with mechanoreceptors. Mechanoreceptors come in and they block ongoing nociception for transmission to higher levels so we can't feel it. That's why we rub ourselves when we hurt ourselves. We stimulate mechanoreceptors, and the mechanoreceptors block the pain transmission. Mechanoreceptors also, doesn't show on this slide, but mechanoreceptors also come forward, normalize muscle activity, and they also block postsynaptically the autonomic outflow so that we can restore normal circulation and normal autonomic function to other organs at that same segmental level that have been altered by this nociception. So what we have with mechanoreceptor activity, by restoring normal afferentation, we restore all these effects of nociception at the spinal cord level. Now, neurons, their function and the health of neurons depend on how often they fire. If you want a neuron to be healthy, you need to fire it. And it's going to fire the next neuron, which is going to keep it healthy, which is going to fire the next neuron, which is going to keep it healthy. So the frequency of firing of neurons is what keeps them healthy. It's dependent on activity. And if we have decreased frequency of firing from deafferentation, then that results, that deafferentation from the of lack of stimulus means there's decreased frequency of firing of neurons, and the decreased mechanoreceptor frequency of firing results in increased nociceptor transmission and pain. So we want to make afferentation as good and symmetrical as possible for a given patient to block pain as well as all the other consequences of pain, including the autonomic effects, locally and at higher levels. And so locally, the autonomic effects are via the intermediate lateral cell column of neurons, and systemically, nociception goes up via the thalamus to the hypothalamus and stimulates autonomic activity. Systemically, you get the fight or flee reaction. And nociception also stimulates a very powerful release of hypothalamic pituitary adrenal axis pathway, releasing a corticotrophin releasing factor, stimulating ACTH release, and stimulating adrenal hormone release, particularly cortisol, as a part of a nociceptive reaction. So nociception that gets into the nervous system and goes to higher levels can affect both autonomic and endocrine changes. So we want to get rid of that. We can get rid of it by blocking the nociceptive input, which is the first thing we want to do with our patients, is get rid of sources of nociception by IRT or NSB or set point. And that causes then a decrease in this fight or flee reaction, which puts the spine in flexion. If you're a chiropractor, you want to get rid of the injuries first so you can have normal afferentation, so the spine's taken out of that hyperflex state so that we can adjust it and manipulate it easier. So we want to get out of that spine inflection reaction. Now, nociception affects the contralateral cortex. Muscle response to the pain. When there's pain, there's this withdrawal response, and those muscle responses affect the cerebellum on the same side, but go and affect the cortex on the opposite side. So we have still affecting the opposite side, ipsilateral cerebellum, contralateral cortex. And the two together then impact the opposite cortex and the ipsilateral cerebellum. And we want to restore normal activity for mechanoreceptor activity, but we also want to block the effects of nociception. And we block the effects of nociception and restore normal muscle work activity, which helps us to straighten out cerebellar activity. Because the cerebellum is going to pick up this altered muscle imbalance from the withdrawal reflex, and it's going to change its firing rate to coordinate the body around that response to injury. The cerebellum is like a football field, and the midline of the cerebellum is related to the spine, and the outer layers of the cerebellum are related to the hand and the foot. This is not anatomically accurate. This is just to give an idea. And so we have this fact that the cerebellum has these different nuclei. The midline nucleus is the fastigial nucleus, and the intermediate nucleus is called the interpositus nucleus, and the dentate nucleus is the farthest out nucleus. And the autonomic effects of cerebellar activity are two that we'll mention. The midline nucleus from the cerebellum stimulates autonomic centers in the lower brainstem. These are the vital centers for heart and digestion and lungs and all that kind of stuff. The autonomic centers in the so-called pontomedullary reticular formation. This is the lower pons and the upper medulla, the vital centers in the brainstem, in the reticular formation. And so asymmetries in right or left afferentation create asymmetries in right and left vestigial output, which create altered autonomic activity at the brainstem level. Further, the dentate nucleus sends a pathway that crosses to the red nucleus in the mesencephalon on the opposite side. There's a spillover from there to other mesencephalic autonomic centers, and therefore asymmetries in right and left afferents cause differences in right and left dentate output, which causes altered autonomic activity at the mesencephalon level. So when we have asymmetrical inputs from deafferentation, we end up with altered cerebellar activity or altered cortical activity, but also altered autonomic activity, both at the spinal cord level as well as at higher levels in the brainstem. and in the hypothalamus. So this is like huge stuff that we do when we normalize afferentation. I mean, think of what we're doing when we balance muscles and free up ranges of motion. You know, you got this fascial sheath, and you're moving this way, you can't move this way. And so you strip the lat out, and all of a sudden the person can move a lot better. Oh, that's good. They can move a lot better. Yeah, they can move a lot better. Their cerebellum can move a lot better. Their cortex can fire a lot better. Their brainstem fires a lot better. And the autonomic activity becomes balanced right to left. In the spinal cord, at the hypothalamus, at the mesencephalon, and in the pontomedullary reticular formation. So all autonomic centers are driven by and affected by, in both positive and negative ways, depending if we get balanced or imbalanced activity. All autonomic centers are driven by mechanoreceptor activity. So it's not just like making the person move better. So people say, boy, I feel better all over, Doc. You've heard them say that. Boy, that's better, but I feel better all over. They feel better all over because you're changing things other than just the muscles and joints you're working on. You're feeding back in and driving the entire nervous system in a symmetrical fashion. And applied kinesiology allows us to know how to do that most optimally. So we have this cerebellum like a football field. And muscle testing becomes an important tool in the decision-making process of what to do for a patient when we have all these different alternatives. We want to diagnose the process, not just the name. And we do assessment. We do a variety of different types of assessment. We do assessment by muscle testing, we do lab assessment, we do assessment by history and other physical exam and neurological exam procedures, whatever you want to do for assessment. And based on our assessment, we do treatment, and we can make lifestyle recommendations. And what we're talking about this weekend is going to be involved with both treatment, but making lifestyle recommendations in the form of dietary recommendations for patients. Many times our treatments are extremely effective, and patients don't get better, because we haven't used our assessment procedures, including muscle testing, to guide us to tell patients about lifestyle changes they must make to not sabotage their care. And we'll be talking about essential fatty acids a lot tomorrow in that regard. And if you don't have adequate essential fatty acids, then anything you're going to do is going to be inhibited in its full response. And the patient's not going to get the response that you want. And sometimes the patient's response will be even negative to what you expect, because if they're in a very pro-inflammatory state, sometimes the things we do actually stir up the patient's inflammation rather than turn it down. That doesn't happen in my practice too often, but it has happened. It's actually happened when I've been treating people in front of a group. Try to get somebody out of the audience, use a pain control technique, and just pushing on it. They're so inflamed. Just pushing on it makes them worse. I've had it happen a couple of times. I'd rather have it happen in my office than in front of a lecture, but it's happened a couple of times, where the patient's injury is just so inflamed, and there's such an inflammatory state because of their bad fatty acids maintaining this inflammatory state, that anything I do just stirs it up worse. And it actually not only blunts, but makes the response even worse than if I didn't treat it at all. But that's the patient's fault. That's a lifestyle issue because they're consuming the wrong kind of fat. So we have to use our assessment, which we'll be talking about how to do this weekend, to make lifestyle recommendations for patients. In this case, this weekend, dietary lifestyle recommendations.